welcome to another podcast. Today we're going to look at head trauma and in particular traumatic brain injury, which we know as TBI. Now anyone who's been in the industry of healthcare, in particular pre-hospital healthcare for a while, will know that head trauma is one of those ones that should be up there with some of your most complex cases that you'll have. They have a lot of considerations, a lot of overlapping considerations when you move from pre-hospital into extended into ongoing care. And sometimes it can be quite difficult to navigate around what protocols or what information suits certain environments and what considerations we should really take into account when trying to provide the best care for our patients. So the goal today is we're going to have a bit of a discussion about traumatic brain injury, and we're going to look at the spectrum of that particular trauma. And we're going to look at considerations that we need to look at first, and then maybe talk about a few that move into that extended space. Okay, but never forgetting that often the best care you can provide for someone in a state with traumatic brain injury is that rapid evacuation to that definitive care where the experts in neurosurgery actually exist to provide that definitive care. Okay, so everything we say after that basically has to come second to that notion that the best care for these patients is not in the field. It's not in the tent. It's not in a facility that can't provide surgery. Okay, it's in a high-level tertiary facility with the correct people to deal with the cause. But looking at an introduction, as we always do, just on a global scale, we'll start defining a few classifications that people have come up with for traumatic brain injuries. So TBI accounts for around 10 million cases worldwide per year. Now this includes mild all the way up to severe, which are the categories used. Okay, so it's a pretty big case, and it's quite a common presentation that people get to emergency departments, even outpatients departments. Now a vast majority of these TBIs are mild. Okay, now unlike other things that are classified as mild, the mild TBIs actually need some acknowledgement and need some sort of investigation and care in order to make sure that that mild TBI doesn't have a particular history and isn't likely to become into that moderate to severe category. Okay, so we do not ignore any patients basically who have a head injury, especially a traumatic head injury. So in order to define a traumatic head injury, we need to know that it occurs when an external force impacts the head and causes that contra coup injury. Now, just for revision, a contra coup means basically when we look at that acceleration, deceleration mechanism of injury, where the actual organ within the cranium begins to rattle. So as the head moves violently or something hits the head, it causes the brain to move inside the skull and therefore bounce off the inner walls of the skull, which can cause damage to multiple areas. The most common mechanisms of injuries for traumatic brain injury are your blast and your blunt and your penetrating injuries themselves. So blunt force injuries are far more common. Blast injuries cannot be ignored. They're some of the most complex. And anyone that has a penetrating injury to the head obviously needs special considerations. Now, over the years, you can do a lot of reading at different types of intracranial hemorrhage. But when it comes down to frontline management, you're not going to know what sort of intracranial hemorrhage they have, or even if they have intracranial hemorrhage, or whether it's not, it is just swelling and contusions of the actual brain tissue. You won't know. You'll just know that it's a TBI. But all forms of intracranial hemorrhage can contribute to the disorder known as a traumatic brain injury. As far as the injury pattern goes, we have two types of classification. We have the primary and the secondary. Primary brain injury are the ones that happen on impact or on penetration, on the initial blast. They are violent in nature and they are irreversible. So primary injuries are irreversible damage, and you pretty much have a state of that's now the new norm that you can try and rehabilitate from. So the goal for all things related to treatment is to actually prevent and manage secondary brain injuries. And that's what we will look at a little bit further as we go through. And that's what all the management are all about. Once you start getting traumatic brain injuries moving into that moderate and severe level, they are extremely life-threatening, they have a high mortality rate, and they need management. But to complicate the management of these particular disorders is 60% of all the severe categories are associated with different trauma. And different trauma comes with different protocols, and it's very difficult to navigate which protocol takes precedence. And unfortunately, there isn't a lot of good answers out there that can be a stock standard rule for everybody. Moving on, I think it's important to highlight a couple of characteristics within the brain and the brain structure, especially to do with intracranial pressure, before we move into the conditions and the management of these disorders. So when we talk about intracranial pressure, we need to know that intracranial pressure isn't a bad thing. It's actually a much needed thing for the brain in order to maintain a pressure around that 5 to 15 millimeters of mercury. And that pressure allows for the rotation and the re-establishment of new cerebral spinal fluid. So the coronal plexus in the brain will actually produce new cerebral spinal fluid, and as it goes around in pressure, and as the pressure gradients change within the actual cranium and the spine, it will cause cerebral spinal fluid to be absorbed and new to be actually created. And that's a way for the actual brain tissue to get fresh influx of nutrients like glucose, and also to rid itself of waste. But there's a certain limit within the cranium. So if we have any interaction within that space, something new comes in that's not supposed to be there, there has to be an increase in intracranial pressure, and that increase of intracranial pressure will actually reduce the amount of cerebral spinal fluid available and reduce the amount of venous volume that's available as well. So its capacity to get waste and its capacity to provide nutrients is reduced. And as that pressure, whatever it is, it can be a tumor, it can be blood taking that space, it can be inflammation, it can even be water like hydrocephalus. As that mass or that foreign material that shouldn't be there in a normal state increases, the worse the damage will actually get, to the point that the mass will actually start moving brain tissue and it will cause the tissue to herniate. Before that, the mass puts a lot of pressure on the arterial walls of the actual circulatory system, which can also make it very, very difficult to get oxygen, fresh nutrients into the brain, and obviously aid in that excretion as well because of the reduction in the venous volume. Okay, so quite often the mass that presents itself in the cranium doesn't just shift the CSF and the venous volume out of the area, it also impacts the arterial flow and causes the brain tissue itself to herniate into areas that can just put more pressure on it, which can actually cause neurological involvement and therefore dysfunction of some of the functions that that part of the brain takes care of. So another thing to be acutely aware of when we're dealing with intracranial pressure and the regulation of the intracranial pressure is a concept known as autoregulation. Now, autoregulation is quite a useful tool, generally speaking, and what it does, it allows for the correct amount of perfusion to be maintained within the brain despite the blood pressure itself. Now, I mentioned blood pressure because that is the main sort of contributor when we're dealing with your autoregulation, but for those that are completeness, this autoregulation concept that we're talking about is only considering the myogenic tone of the actual autoregulation. That means whether or not the vessels dilate or constrict. Now, there's three other variables that play a role in autoregulation, and they are your neurological response. Okay, same as any other neurological response will cause your vasoconstriction and your dilation. And you also have a metabolic mechanism, and that's where your CO2 comes in. So autoregulation from a myogenic point of view doesn't actually involve the neurogenic pathways for androgenic or cholinergic stimulus, and it doesn't take into account metabolic overrulers like PaCO2. So the amount of CO2 in the blood can actually affect the diameter of the vessels as well. And the last one is the considerations of the endothelial membrane. As we've spoken about before with general inflammation, it's the endothelial membrane that releases a large amount of systemic and localized inflammatory mediators, which obviously play a role in whether or not dilation or hemostasis, constriction, occurs. Okay, so just keep that in mind, that whilst we're looking at autoregulation being related to MAP and the blood pressure, there's also other variables that can overrule that can be a consideration in management. But looking purely at that myogenic tone, what happens is as the blood pressure drops, the vessels in the brain will actually dilate. Now, this may seem counterintuitive for a pressure point of view, but what it's allowing it to do is to actually have more blood stored in the brain as it's pumped in. So it slows down the flow of blood in the brain in order to increase the amount of physical blood that's available to the brain tissue, compensating for that low MAP blood pressure. Now this works all the way up to 150 millimeters of mercury MAP, not blood pressure systolic, and where if the pressure is too high, it will actually cause vasoconstriction to reduce the amount of blood flow that's available in the brain. And it does this obviously to protect and to create a homeostatic relationship that the brain wants in order to be able to function properly. Now, if we go on the extreme ends of blood pressures, like way too low, then the opposite effects occur because we often get some of those other mediators coming in. And when we want larger vessels, we get smaller. And if we go way too far up, the mediators will actually cause vasodilation, which means you no longer can compensate. So this is something that's built in for compensatory purposes within an acceptable range. As we go to the extremes, we no longer have that ability to do it. Now, when we look at blood pressure here, and we look at blood pressure for autoregulation, we are talking about mean arterial pressure, not systolic or diastolic. And there is a strong relationship between cerebral perfusion pressure and mean arterial pressure that we'll look at now, just as a means of giving you awareness. So mean arterial pressure forms part of the equation when you're trying to figure out what cerebral perfusion pressure is. So cerebral perfusion pressure is MAP minus intracranial pressure. And there's a relationship between intracranial pressure and mean arterial pressure that allows for perfusion to occur. And this MAP is very important to look at, and we'll have a deeper look at it when we look at pathophysiology of how that relationship works. But think of it the same as if you're dealing with heart failure. You're dealing with hypertension within the heart. If you have hypertension in the afterload area, the left ventricle is going to have to work harder in order to create more pressure greater than that hypertension. And that's sort of the relationship that we deal with the MAP and the ICP. So if the ICP gets too high and the MAP gets too low, then we won't actually get any perfusion to the brain. And that's the worst case scenario. So when we're dealing with normal cerebral perfusion pressure, it's 60 to 70 for adults. So 60 to 70 millimeters of mercury is your normal optimal cerebral perfusion pressure. Now, obviously, you can get a little bit lower, around to that 50 mark. Once it gets much lower than that, then we start to get quite catastrophic. Now, normally speaking, your intracranial pressure sits between 5 to 15, 7 to 15, depending on where you read. And pathologically speaking, raised intracranial pressure symptoms start to kick in when intracranial pressure is around that 20 to 25 millimeters of mercury. But obviously, the higher the pressure, the worse the symptoms. Okay, so they're the gradings that we work with. So if we work on a normal one, and we work on a normal MAP of around 90, and we work on a normal ICP of around 10, then your actual CPP can sit around 80 millimeters of mercury, which with auto regulation will be adjusted to around that 60 to 70. Okay, so that's the relationship it works in. Now, for those that don't know, in order to calculate MAP, the easiest way I find, there's a few different ways, but the easiest way I find is to get the diastolic value and then plus 1/3 of the difference between systolic and diastolic pressure. Okay, so just in the case of 120/80, because it's textbook normal, if you start with 80 and the difference between systolic and diastolic is 40, 1/3 of 40 is 13, so it's 80 plus 13, that gives you a MAP of 93. Now, if you don't want to do the maths, luckily our monitoring devices will actually provide us MAP, and that's the number written in brackets whenever you take a blood pressure on most of our monitoring equipment. Now, the reason this is important is because a lot of protocols will be predicated around systolic because it's easier. But if you know that MAP is a very important value and you have someone with a significantly low diastolic, sometimes it can definitely be something to discuss because it doesn't matter what the systolic's sitting at, it's got to do with what that mean arterial pressure is that's influencing those cerebral perfusion pressures. So as a general rule of thumb, as the ICP increases, MAP needs to increase to compensate. And that's how you start hearing about stories where people are on long-term management for traumatic brain injuries and their optimal blood pressure is 160 systolic. They often get these really high numbers to compensate for what's happening within the brain. Obviously, they do that under monitoring and all the rest of it, but it also indicates why we, in our protocols, in the primary healthcare position, has the optimal blood pressure, systolic, between 100 and 110, as opposed to the traditional 90 that you'll find in most other trauma-related protocols. Okay, moving away from standard physiology, we'll have a look at our pathophysiology of that secondary brain injury. So remember at the start in the introduction, I said that primary brain injury is what it is. It's tissue damage and that's it. So most forms of violent head injuries will cause an element of primary tissue damage. You can't get that back. But unfortunately, because of that primary tissue damage, you can get effects from that particular damage, but also the surrounding tissue that may not be damaged, but are subject to edema, so increase in fluid coming into that area, so sort of like a localized hydrocephalus, and then also this inflammatory mediators from the endothelial in the actual tissue themselves. So you can get this increase in edema and increase in swelling as a direct result of the primary injury, and even if it wasn't a true primary injury, it was just enough damage to cause that inflammatory response. Now that in turn will increase your ICP, obviously because you're causing swelling. You will have to compensate for that in order to, because there's only so much room within the vault, you'll have to compensate. So quite often the first thing that compensates is what we just spoke about. We'll get that cerebral vasoconstriction. Okay, and then that alters it in order to help reduce the intracranial pressure. So instead of having large vessels with large blood flow, it shrinks, reducing the space, therefore reducing the intracranial pressure. Unfortunately, this is one of those things that overrules autoregulation. Okay, we're talking about metabolic mixed with endothelial autoregulation as opposed to biogenic. That result of vasoconstriction reduces perfusion. And that perfusion to the brain causes cerebral ischemia. And that ischemia obviously leads to a dysregulation of brain function, which in turn can cause increase in systemic vasoconstriction. So therefore it increases the blood flow to the brain, which in turn increases ICP. And this is a constant battle that the body will go through as a means of trying to protect the brain by reducing its actual internal vascular or realistically venous volume and CSS volume in order to compensate for the raise in the mass that's in the middle, as we spoke about with Morel Kelly's doctrine. It will keep doing this battle until it can no longer do so, until all the pathogenic mediators build to such a point that it can no longer compensate. And when that happens, we start to get to a point where ICP and MAP are basically the same level. They're not exactly the same level, but basically a level that is not conducive to perfusion anymore. So the ICP is too high and or the MAP is too low in order to perfuse the brain. And that causes a decrease in that cranial perfusion pressure. So these mediators that are occurring constantly as a fight between reducing and increasing intracranial pressure, there's obviously going to be a limit that pressure becomes so great and the MAP can't keep up, or in most cases when we're dealing with severe head injury is we have another trauma response that's causing actual MAP problems within itself, whether that's hemorrhage, whether that's burns, whether that's something else that causes a shock state in the body, which means you're already starting on a deficit of MAP, which means you need less of an increase in ICP in order for it to be a problem. But once that point happens, once you get that tipping point where perfusion and pressure can't actually compensate for the intracranial pressure, then you move from the secondary injury compensatory phase into decompensation. And decompensation lasts for a varied amount of time depending on how violent it is. But what happens is you get a decrease in cerebral perfusion pressure, which increases the amount of ischemia that occurs, and in lots of cases can actually cause brain herniation, and that herniation and ischemia causes brain tissue death. And obviously, because the brain is responsible for many vital functions of the body, if not all, we obviously get those physical manifestations turning into systemic symptoms. So everything we talk about as far as management goes is to keep them regulated within the secondary injury and compensatory mechanism state for as long as possible, sometimes long enough to heal and to basically no longer have that damaged state, but in other cases just keep them in that state long enough in order to get to that definitive care. And that's the management principles of someone with a traumatic brain injury. So let's take that information and we'll start looking at some clinical presentations that come across when we're dealing with our traumatic brain injury. So as we're going through treating our patients, we need to obviously always consider the mechanism of injury. If there's a state where somebody could theoretically have a head injury, then we sort of need to investigate for it. The main metric that's used to define mild, moderate, or severe is mostly the Glasgow Coma Score. Okay, so Glasgow Coma Score is very important in head injury, and it's actually the reason it was invented was because of head injuries and neurological problems. So the fact we use it for everything is fine, but it's definitely used for these cases. So GCS is a must, but you can start with AVPU. Mild, you're looking at GCS 13 to 15. Okay, so they're the alert state. Moderate, GCS 9 to 12. Okay, so that's when we start leaning into that VP state. And severe is 3 to 8, PU state. Okay, so we have to denote where they are. Now, GCS can be overruled when we start looking at our red flags. And some of our red flags can be taken from doing a good peril, so good pupil examinations, pupil equal, reactive, round, and accommodating. Look at our vital signs and look at our motor extremity response as well. Because if you have someone that's GCS classified mild with a red flag, then they actually start getting managed more as a moderate to severe as opposed to a mild. Okay, so there is that overlapping difference that we'll talk about in management, but the red flags denote that there's a higher probability of something being wrong. So even if they may be in a mild state now, they have an increased probability of going to a moderate or severe state. So this includes witness of loss of consciousness. Now that's not amnesia, this is loss of consciousness. Okay, amnesia, technically, you can have up to 30 minutes lost in some papers and still be classified as a mild traumatic brain injury. Okay, so don't think about amnesia, think about conscious state. If you've had exposure to blasts, basically other mechanisms of injuries that denote traumatic brain injury, in the last 3 days. So if you have back-to-back ones, we know that reoccurring concussions are very bad, so we look out for that as well. Any unequal pupils are definitely something to look out for, and it can actually be the first indicator that you'll see when you're dealing with changes in that response between mild and moderate. Can be those pupil changes. Unusual or combative behavior, repeated vomiting, seizures as a result of head injury, worsening headache, double vision, weakness on one side, can't recognize place, time, or basically just general disorientation, and the inability to speak is another one. So any of those ones is your red flag, and then we start to push them up a little bit into that moderate category. Speaking about the difference in management, okay, we'll start with our mild, because remember, they cannot be ignored. They actually have a special management that needs to be done, and it's really looking at that concussive state and protecting people long term for that concussive state. Anyone who loves reading, there are plenty of studies out there that are demonstrating that constant, reoccurring, undermanaged concussions are starting to have long-term effects, whether it's punch drunk syndrome or whether we're looking at PTSD. There's huge amounts of links that are starting to form within that concussive space. And most of the studies are actually coming from the sporting industry, if you're interested in having a look. Okay, but generally speaking, as I said, GCS 13 to 15 with a history or a potential history of a head injury. Okay, they are in the mild state. Mention the red flags, always look out for them, and then we manage them accordingly. We don't forget the principles that are important for head injuries, which is hypoxia and hypertension. So if required, if something else is going on in their body and they have vital signs conducive to hypoxia and hypertension, we absolutely manage those. Okay, we always manage those. Now, in regards to MACE2, realistically the recommendation is if anybody has symptoms or reason for you to believe that they have a head injury and they're in a state that they can actually communicate and answer questions, then it's recommended to do a MACE2 assessment when appropriate and when possible. Obviously, there's times and scenarios where you just can't do it, but you want to do it as soon and as close to the point of injury as possible. So you conduct the MACE2, and we won't go into too much detail on that because it's quite involved, and realistically, you use the tool. You don't try to memorize it, you use the tools that are provided. And part of that tool that's provided is also conducting a vestibular ocular motor screening as well. And the details of that are also found online. You just type in MACE2, you'll find a download if your organization doesn't already provide it. Other things you can do in the long-term management is, as you're monitoring these people, do a proper ophthalmoscopic exam. Now, the reason I say that is whilst you can get involved in fundoscopies and all those rest of things is because pupil changes are the first thing to change when you're moving from mild to moderate, and pupil changes can be very difficult to pick up. And the main change that happens is a reduction or an increase in size of the pupil. Okay, mostly an increase in size occurs as a result of mild to moderate head injury. So if you use the grid aspect of your ophthalmoscope and you have an indicator of distance to the eye, sometimes using a finger pointing out, placing it on the person's face as a metric of distance, you can denote where the pupil sits on that grid. And then as you continue to do it, it'll be more easier to pick up subtle changes as opposed to you trying to think whether it sits between a 3 or a 4. Okay, so that can be a recommendation. Obviously, doesn't overrule the management of hypoxia and hypertension. Okay, from there you make a decision. Okay, if you can hold on to them, you definitely hold on to them and you monitor them. Okay, you keep them with you, you keep monitoring, you keep checking them right throughout the time. 24 hours minimum is the recommendation. Okay, you can talk to people. Sometimes they'll let you get away with 4, but in reality, 24 hours is a good amount of time for holding on to someone who's been, you believe, has a mild TBI. Okay, there's also the option to evacuate. If you can't hold on to them because you don't have the means to monitor them long term, then evacuation is recommended because you don't actually want to put them in a situation where they can get another head injury for at least the 72-hour mark, okay, and can be negotiated to 24, but it needs that conversation. Okay, so that's the main considerations you need to do. In the event you get an abnormal or any of the red flags when you're doing the MACE2 or as you're monitoring them, then they need to be escalated. The management and evacuation needs to be escalated, as too does reoccurring mild TBI. So even outside of that 72-hour red flag window, if people have had mild traumatic brain injuries in the past, it warrants further investigation. The only variable is when that investigation occurs. Okay, moving from mild, we'll move into moderate and severe. Now, the complication thing about this, to remind everyone, is when we're dealing with severe, so we're dealing with that GCS 3 to 8, then we're often associated with additional trauma. Okay, for someone to be in that severe state, 60% of the time, especially in our line of work, it results in additional trauma, which makes things very difficult. Okay, so these are the people that have a GCS less than 13 with a history of head injuries, or they have one of those red flags. Then we do the same. There's overlaps. We either treat or prevent hypoxia. Now remember that sometimes hypoxia could be caused by another reason. Hypoxia can obviously be caused by head injury alone, depending on how bad the head injury is, but most of the time it involves some sort of other mechanism. So you've got tension or hemorrhage itself. Okay, so make sure you address those other things that it could be as you're preventing hypoxia. The goal is to have it above 90 to 95. You want it high SpO2s, so 95 is generally the metric. If you can't get it above 90, and you're trying positive pressure ventilation, you're trying to give them supplementary oxygen, you're putting in basic adjuncts, then you could consider a definitive airway. And this is where the Crike versus LMA really comes into play. And a lot of the time, especially in the modern teachable C manuals, they're moving away from LMAs, mostly because of this state. And when you have patients like this, they can need a definitive airway, but they may not be far enough to be able to tolerate a laryngeal mask or an iGel. So you're in a position where we either look at RSI, which is inherently dangerous in these cases, and take a huge amount of skill, or we try to favour Crike. But either way, Crike realistically is a better point of call for these patients, and we ventilate through there in order to keep that SpO2 above 90. And that's the goal. Right, so definitely have some conversations, but you must prevent hypoxia in these patients. The other thing that must be prevented is that hypertension. And as I mentioned before, the metric is a systolic blood pressure between 100 and 110. And a lot of supporting papers, it will actually favour over 110 millimeters of mercury. Okay, but if you aim for 100 to 110 for starters, and then if your management continues, you can start to have conversations. Fluid resuscitation is important in order to get them above that 100 millimeters of mercury, and you want to use whole blood if there's hemorrhagic shock and if you have it. So if you have whole blood and they're in hemorrhagic shock, they've got that other additional trauma, you want to give them the blood. If there's no evidence of other injury, then for someone to have hypotension, you're dealing with a very decent head injury. Okay, hypertension from head injury alone is quite a late sign and quite a severe sign. Okay, there's a high rate of mortality. So you want to be quite aggressive with the management for these particular patients. Okay, so you want to give 1 to 2 litres of normal saline in that case. Now, in the event somebody is hypertensive and you're not carrying blood, then you have a conversation. Okay, because there are supporting protocols in the PFC manuals that says that evidence of providing 1 litre of normal saline to target that systolic blood pressure that's desired is better than obviously giving nothing and allowing them to be in that hypertensive state. Okay, so if in the event you don't have blood and someone is hypertensive with a moderate to severe head injury, a phone call can be made to discuss the management options that you do have. Now, in the event you have someone that has a sign of a moderate severe TBI and they also have hemorrhage, then we have a conflation of protocols, because point of injury care will often have us resuscitate to what's been coined permissive hypertension, and that is around that 90 millimeters of mercury. And until that gets investigated and evolves over time, that's pretty much what we stick with for a lot of good reasons. Okay, so that's the metric. But obviously we know that aiming for a 90 millimeters of mercury is subpar when dealing with a traumatic head injury. So you want to know which one is actually favorable to go for. And in reality, we don't have any good answers on the ground, and it's actually recommended, most protocols, to consult experts in the field. Okay, if the best expert you can get is a medical officer, then that's what you get. But in the case that you can get someone higher and more knowledge in this space, then obviously consult them for better management. Unfortunately, that is the best we can get, because it's not an easy question. Okay, there's no easy data to that one. Right, moving on, we also want to give TXA. TXA is administered in order to help control any hemorrhage either in the brain or around the body. Okay, we want to keep them in that place. Analgesia is one of those ones that often gets questioned. Is, oh, you don't give analgesia for anyone with head injuries because it's a big no-no. Okay, and that's all well and good until you've got somebody with complementary problems, in a lot of pain, and that pain and anxiety and all that other stuff is actually causing physiological problems. And analgesia is actually a good point of call. Ketamine is not contraindicated for head injury, and it also has the best probability of not lowering somebody's blood pressure and respiratory drive. Okay, so sometimes ketamine is the best point of call. If you give opioids, then it can really affect your further observations of that particular patient. Okay, as too can ketamine, so it is given with caution, and it is given on recommendation. So, but do not believe for a second that it is an absolute contraindication, because there are cases where patients will legitimately need analgesia, and a conversation should be had about proper pain management for these patients. We can also have a discussion about the position that we put these patients in. Now, generally speaking, these patients will be supine, okay, because they have some involvement with C-spine. We want to keep them in line, okay, but raising them into a position of 30 degrees minimum can be very good at helping venous drainage of the brain in order to reduce that ICP. So a lot of the times it's recommended with signs of herniation, but it can be recommended in normal state and out of those signs of herniation if the person isn't in a shock state. So if you're just dealing with a head injury and there's no signs of additional shock or additional trauma, then having someone in that 30-degree head elevated position can help drainage, as too can keeping their head in line. It works well for the C-spine control, and it also helps with drainage of the head as well. Okay, if you have the head turned, it actually reduces the amount of drainage that's possible for the intracranial pressure. Okay, so just keep that in mind. As we're going along, we need to monitor for signs of herniation. Okay, so signs of herniation are the worst signs we can get, and they're one of those ones where a lot of the radical management of casualties will actually come into play. And the things that are more aggressive to do in a pre-hospital environment are considered at times of herniation. Okay, so when we talk about those, a lot of those ones, they're not needed really unless you have signs of herniation. So herniation management on the ground is best done when you're en route to somewhere to get surgical intervention, or you're in a facility where you're waiting for surgical intervention. Then aggressive management for signs of herniations can be considered. And in reality, they're really only considered for 20 minutes. So you do the aggressive management for 20 minutes, and then you go back to mainstream management for herniations in a pre-hospital environment, and always on consultation. So some of the things you would have heard about associated with herniation is Cushing's triad. Now, Cushing's triad absolutely is the triad associated with herniation, but it is a very late sign. So for memory purposes, Cushing's triad is bradycardia, a systolic blood pressure widening from the dystolic, so a widening blood pressure, and chain-stoked breathing, or really erratic breathing. Okay, but earlier signs of herniation can be just a decrease in neurological status and really your dilated asymmetrical pupils as well. Can be those early signs of herniation. And from there, the use of hypertonic solutions can be considered on order. And we're looking at 250 mils of 3% normal saline over 10 minutes, and it's repeated in 20 minutes with a max dose of 2. Okay, and that's obviously on order, but that can be a management. Another management that often gets spoken about but really is not mainstream management is when you hyperventilate somebody. Now, this is only done when somebody has airway adjunct and only done if you have end-tidal CO2 monitoring, because there's a limit to what you want hyperventilation to be done. So the whole point of hyperventilation when people talk about it is they want to decrease the amount of PaCO2. And they want to rely on that metabolic autoregulation to cause vasoconstriction within the brain. And that's what they're trying to do when they're hyperventilating. And obviously, that's going to be effective at reducing ICP, so reducing that herniation effect. But obviously, long term, it's going to create a massive problem with cerebral perfusion and potentially increase cerebral ischemia. So people really only recommend it as you're going into surgery, as you're buying that last little bit of time, and really only recommend it for 10 minutes as a general rule of thumb. So in reality, unless you have fixed airway, end-tidal CO2 monitoring, and you're about to go into neurosurgery, it really is one of those ones that will give you 10 minutes and then possibly cause more damage to the brain. Okay, so the reason I'm going through these particular things is because I know personally that hypertonic saline, hyperventilation, raising the person to 60 degrees head, all these things come into play when you're dealing with just normal conversations about head injuries. Okay, but statistically speaking, these head injuries are the severe end, which are rare, and these signs are the signs of somebody that has a high mortality rate, and these are the people that generally die. Okay, and these managements that we're talking about are really only effective when you're about to go into surgery, and they're not able to be continued long term without advanced monitoring. So hypertonic solutions can be used more readily than hyperventilation, but you sort of need that ongoing monitoring and advanced care before we start looking at using it long term. Okay, so very rare to get, very desperate times, very bad patients, and if you don't have all those variables lined up in your favor, it's a real consideration of whether or not you go down this route or you start looking at taking more of a palliative approach as opposed to a management approach itself. As you move into extended or ongoing care, some other things can be considered. And other things that are often spoken about when we're dealing with head injuries that sort of just need mentioning, okay? Because head injuries are excessively complicated. Now, in the event you want to get an adjunct, you don't have much, and you want to sort of increase the ventilatory support, oxygenation support of somebody, is NPAs can be used in head injuries, okay? It's actually recommended as a minimum protocol when we're dealing with PFC, minimum better best. It's recommended as a minimum protocol, nasopharyngeal airway with a bag valve mask, okay, in order to maintain the SpO2 above 90. Okay, so it can be done, even though there used to be an associated risk of putting the nasopharyngeal in a basilar skull fracture. Okay, so it is a recommendation on top of that. Now, nasogastric tube is one of those things that is fraught with danger when you're dealing with head injuries. But in reality, if you're providing IPPV for a BVM, especially if you've got PEEP, then you need a nasogastric tube. Now, it can be an orogastric tube, okay, it can be a nasogastric tube. The recommendations, if you're using a nasogastric tube, you feed it down the nasopharyngeal airway. Okay, that way you know that you're bypassing the actual basilar plate and it's going into the gastric contents from there. Head injuries tend to lead to seizures. So seizure activities need to be controlled as soon as possible. So predict seizure activity and long-term management and control them as they come up. Other things that tend to happen long-term with head injuries, either associated with infection or not, is patients tend to get fevers. And patients in a hypothermic state will actually respond better to traumatic brain injury than those in a hyperthermic state. So it's recommended to control fevers with 4-hourly paracetamol if you're holding on to patients or in a facility where you have a patient with a head injury. Other long-term considerations need to be glucose. Glucose must be monitored and continuously monitored in order to be maintained at an appropriate level. Probability of having hypoglycemia in our demographic with a head injury is possible, but not really probable. Okay, so definitely test for it, but ongoing management is one of those ones that needs to be tested for. As to the sodium. Now, sodium risk is inherently lower than people may think. People often think that if we're using things like hypertonic saline, then we're going to be really raising somebody's sodium levels. And obviously, that is a consideration that needs to be considered. But the good people have done a little bit of maths for us that can help quantify that risk state. Is you've got, generally speaking, an 80 kilogram patient, okay, and let's just say that they're sitting at that 140, which is the max norm level. So 140 millimoles per litre is the max normal sodium level for the blood. Okay, and we start giving them 3% saline, 250 mils. Now, 80 kilogram patient, that raises their sodium 2 to 3 millimoles per litre. So when we start to get to the concerning end of sodium levels, we're looking at 160 millimoles per litre. So you're talking realistically 6 treatments of 250 ml 3% saline before it will go from 140 to 160, generally speaking. Obviously, it needs to be monitored. So if you're on the ground and you're giving normal saline, no risk. If you're giving hypertonic saline, your 2 bags, okay, the risk there is also not very high. Okay, is something that needs to be monitored long term, but nothing to really get your head stuck in when you're dealing with that frontline management of these patients. Okay, bottom line with all this head injury management is it's a large topic. It's not an easy topic. It's fraught with high mortality rates and a huge spectrum of complexity from concussion that often gets undermanaged all the way up to severe, which basically tries to get managed, but most of the time in the wrong facility, don't survive. Okay, high mortality rates when we're dealing with severe traumatic brain injury. And these are the patients that sit in the realm of discussions, and good discussions, when we look at palliative care and how much we can physically do. Because when we consider intracranial hemorrhage causing raised intracranial pressure to the point of herniation, the management for that is a craniotomy or a borehole. Now, there's only so many people that can do those successfully and do those well, and they're often aided by things like a CT and a whole theatre of specialists. So if we don't have a CT and we don't have neurosurgeons, then big question comes down to what do we do with these patients? Would they survive with those things? Maybe. But if we don't have it, then we need to start considering that we transition our thought process, maybe lean more towards palliative, and we accept the fact that they're in a pretty shit situation and there's only so much we can do. But what we don't do is we don't grab protocols, we don't grab information designed for high-end management and tertiary facilities and considerations that are considered on the extreme ends, like Cushing's triad, and use them as a basic metric of traumatic brain injury management. Is what that does, and what that tends to do across the board, is result in a undermanagement of mild head injuries, which are our most prevalent by far, and then a almost misconception of what is possible when we're dealing with moderate severe traumatic brain injury. But until next time, take care.